Methamphetamine is a psychostimulant that blocks the reuptake of the monoamines as well as promotes the release of monoamines from the terminals. This makes it somewhat distinct from some of the other psychostimulants, which simply block reuptake. So this is a diagram from the Paulson Stewart article in JAMA Psychiatry last year that talks quite broadly, talks about many interesting facts about methamphetamine. So somewhat famously, methamphetamine, shown in the red, inhibits the vesicular packing of dopamine into vesicles so that you get a higher concentration of free dopamine in the synapse, which then leads to the reuptake inhibitor reversing its action and actually pumping dopamine out of the cell instead of taking it up. There's also a lot of interesting work about methamphetamine increasing reactive oxygen species to cause oxidative stress in cells, as well as questions about its ability to activate toll-like receptors and then affect downstream transcriptional pathways. Intoxication with methamphetamine follows the kind of typical psychostimulant pattern of seeing euphoria, increased energy, decreased need for sleep, loss of appetite, impulsivity, and psychosis. I think among the abused psychostimulants, I think clinically of methamphetamine as being the most associated with development of psychosis. Certainly as a clinician, if I hear that a patient's only psychosis happened when they were actively using methamphetamine, right, that's very comforting. I don't think the patient has a primary psychotic disorder. I think they have methamphetamine use disorder. Methamphetamine use disorder has high comorbidity with other psychiatric disorders and some comorbidity with other substance use disorders. There's a lot of questions about impulsivity, and is something like, does substance use, particularly of psychostimulants, lead to increases in impulsivity, or is increased impulsivity responsible in some ways for contributing to the development of stimulant use disorders? It's probably both of those things. And diagnosing methamphetamine use disorder follows the same DSM-5 pattern for all substance use disorders. Typical symptoms include maladaptive pattern of use with craving. So the addition of craving was one of the big changes going from DSM-4 to DSM-5. And the dropping of legal consequences as being part of the diagnostic criteria. But tolerance, withdrawal, craving, uncontrolled use, using more time, larger amounts, a use that interferes with important social occupational functioning are all part of the diagnostic criteria. Okay, so this is just to give you a sense of where are we nationally in terms of the rates of methamphetamine use. The most recent data are from the 2019 National Survey on Drug Use and Health. And the map shows is a conglomeration of 2018 and 2019 data. So a couple of things to note is that, so this is National Survey on Drug Use and Health. This is methamphetamine use by people ages 12 or older, 12 to 17, 18 to 25, 26 or older. We know the highest rates of use for most substances, including methamphetamine, are among the 18 to 25-year-old group. And it's been holding pretty steady at about 1-ish%. We know that about 2 million Americans used methamphetamine in the past year, and about 184,000 used methamphetamine for the first time, and about 1 million Americans meet criteria for methamphetamine use disorder. This does have a regional variation with areas like the West Coast, Oklahoma, having some of the highest rates of methamphetamine use. I was actually surprised to see Texas this low. I would have guessed that Texas would be closer like to the Oklahoma rates of methamphetamine. And some of that may have to do with sort of urban versus rural distribution. Methamphetamine has traditionally been thought of as really being a substance used by folks more in rural locations, although that In terms of past pharmacotherapy trials for methamphetamine use disorder, many medications have been demonstrated to be ineffective in the treatment of methamphetamine use disorder, including antipsychotics, selective serotonin reuptake inhibitors, tricyclic antidepressants, anticonvulsants, and muscle relaxants. That's like the topiramate and baclofen. Atomoxetine as the non-stimulant reuptake in monoamine reuptake inhibitor has been tested, varenicline. And then there's this open question about the psychostimulants. Possibly open question depending on who exactly you talk to and which literature you're paying attention to. So as we know, agonist substitution therapy using methadone or buprenorphine is really the mainstay of treatment for opioid use disorder. And so by analogy, using a long-acting psychostimulant like modafinil or lisdexamfetamine or methylphenidate would seem to be kind of the obvious thing to try for methamphetamine use disorder. Those studies have had really mixed results, and that's true across both the methamphetamine and the cocaine use disorder literature. Potential for some efficacy among high patients at quite high doses of the psychostimulants, but not the overwhelming demonstration of efficacy like that we have for buprenorphine. Historically, trials of pharmacotherapies for the treatment of methamphetamine use disorder have really struggled with low medication adherence, as low as 30 to 50% adherence, which really makes it hard to test whether or not a medicine works. You need, 70 to 80% medication adherence ideally for us to really say the patient's had enough medicine exposure, had good blood levels of the medicine for us to know if this works. And in some of this work, it's not clear, does the medicine not work because it's not an effective treatment for methamphetamine use disorder, or this study was unable to demonstrate benefit because the adherence was so low. Right, and this is some work that I put together actually for a CPD poster a couple of years ago to try and get a sense of, okay, what is the actual literature that we have on bupropion and naltrexone. Bupropion is an atypical dopamine reuptake inhibitor that is FDA approved for the treatment of major depression, as well as FDA approved for smoking cessation. And then naltrexone is an opioid receptor antagonist that is FDA approved for the treatment of both opioid use disorder and alcohol use disorder, and has a long line of literature that suggests that in general naltrexone is anti-craving or anti-rewarded behaviors. Naltrexone is effective for the treatment of pathological gambling. There is some evidence that it is effective at decreasing compulsive self-injury or non-suicidal self-injury, which suggests that there's this sort of like dopamine motivated behavior effect that it's able to block, likely through its action in the ventral tegmental area and the opioid role in modulating dopamine cell firing. So if we look, so you've got these top two lines are animal research. So arrow down is decreases, arrow up is increases, and the null symbol is no effect. We can see quite broadly that in animal models, naltrexone decreases self-administration of abused substances across classes, and it also decreases cue responding. So that's our animal model for what we think humans probably experience, in which they are exposed to cues, and then the cues lead to a return to drug taking. When we look in the human literature shown on the bottom, again, you can see this sort of, lots of different human laboratory models, as well as clinical trials. Naltrexone decreases substance use, decreases craving for substances, decreases cue responding, that's done in the human laboratory. Relapse, use is what it sounds like, decreases either the amount taken, sometimes it decreases the number of days on which the substance is used. Relapse is a person has stopped using the substance and then you look at time until people return to substance use. And so this is technically the FDA approval for naltrexone for opioid use disorder is in prevention of relapse. We know it decreases use as well. Then we switch over to bupropion. The bupropion and nicotine literature is really interesting. One would, knowing that bupropion is FDA approved for the treatment of smoking cessation, and that the way it's used clinically is that patients start taking bupropion and then set their quit date and stop smoking. One might theoretically predict that bupropion would decrease nicotine self-administration in animals. It actually has the literature is all over the place as to whether or not bupropion affects self-administration. And then also paradoxically increases Q responding, which is again not what we would expect of an effective treatment. But when you look in the human literature, bupropion does in fact support patients in smoking cessation and decreases their likelihood of returning to smoking. Bupropion has not been super well studied for cocaine, but for methamphetamine, it decreases or doesn't affect methamphetamine self-administration, blocks or decreases all of the aspects in humans we can measure. And then when you look at the combination of naltrexone and bupropion together, this is also a very interesting question. So the combination does have an FDA approval for weight loss in humans. And the way that's talked about the weight effects of the combination of bupropion and naltrexone in some parts of the literature are talked about as a satiety effect. If you're familiar with the neuroscience literature, it really seems more like an anti-craving effect, and that it has some role in making it so that patients aren't quite so driven to overeat and to kind of like get that dopamine release. But there's lots of interesting neuroscience questions that could be asked about naltrexone and bupropion in food in humans. And then the specific questions that were tested in ADAPT-2, which I'm about to talk about, are whether the combination would decrease use. And there's sort of an embedded relapse prevention question, although that is not actually explicitly tested. Okay, so now we're going to talk about the ADAPT-2 trial. This work was published in the New England Journal of Medicine earlier this year. And as Julie mentioned in the beginning, I was part of the lead team that developed and implemented the trial. All right, the objectives of this study were to assess the efficacy of extended release naltrexone, which was given as an IM injection once every 3 weeks, as well as extended release bupropion, which is a pill, 450 milligrams oral daily, as combination pharmacotherapy for patients with methamphetamine use disorder. And the efficacy was assessed as being a responder, in which patients, to count as a responder, had to show 3 out of a possible 4 urine drug screens that were negative for methamphetamine during the 2-week evaluation periods. And we're going to go through this primary outcome in much more detail. And then the secondary aims were what everybody's secondary aims are in clinical trials, assess the safety of the combination, as well as assess other drug use outcomes and quality of life scores. The key inclusion and exclusion criteria for the trial, the patients had to meet DSM-5 criteria for moderate or severe methamphetamine use disorder, which is they had to have at least 4 of the 11 criteria. This study, as you can see, was particularly interested in patients with moderate or severe disease and heavy methamphetamine use, kind of who are the most ill patients. And so that was operationalized as patients who self-reported methamphetamine use on at least 18 of the 30 days prior to consent. And in truth, most patients used most trial participants used methamphetamine much more often than that. And then one of the key factors in addiction pharmacotherapy trials and looking at end of treatment use or not is often actually whether or not patients are actively using at the time they enter the trial. The patients who have already started to decrease or stop their use in the weeks leading up to entering the study are much more likely to be able to sustain that throughout the trial. And so we wanted to be sure that we were not getting a heterogeneous population of patients, that we wanted people who were actively using at the start of the trial. And so in addition to reporting it, methamphetamine use on at least 18 out of the 30 days prior to consent, they also during screening had to have at least 2 urine drug screens in a 10-day period that were positive for methamphetamine. And there were 2 days in between each urine drug screen to ensure that we weren't seeing carryover of one day's results onto the next day. Patients had to be interested in stopping or reducing their methamphetamine use. They could not be currently in formal addiction treatment. So no patients who were actively in IOP, PHP, residential treatment. They could have an individual psychiatrist, they could be, or individual therapist, and they could be in a mutual help group, but not in formal addiction treatment. We really wanted this to be a test of medication, not a test of medication plus treat other kinds of treatment. And it had to be medically safe for the patients to be treated with a medication combination. So for bupropion, that meant no seizure history, and we spent a lot of time thinking about old head injuries and what patients we thought would be safe to be on high dose of bupropion. And for Naltrexone Safety, it was about liver function. Liver enzymes had to be within 5 times the upper limit of normal. There could be no elevation in bilirubin. And they had to have platelets above, I think, 50, but it may have been higher than that. They had platelets that were high enough that it was safe to give an IM injection. So this is the overview of the study design. ADAPT-2 had a couple of unusual features. So then the normal stuff is that it was double-blind, randomized, and placebo-controlled. One of the unusual features was that it used the SPCD as sequential parallel comparison design. And what that includes in it is this, in the initial randomization, more patients are randomized to placebo. And then those who do not demonstrate a response to placebo are then re-randomized partway through the trial. And while the trial was ongoing, the ratio of patients who were randomized to the active medication combination versus placebo and the timing of re-randomization were blinded to the study sites. So this is sort of an interesting IRB thing. There was a separate statistical analysis plan that was sent exclusively to IRBs and not to site staff to keep some of these aspects of the trial design blinded. And when we talked to the sites about it, we would say things like people who are randomized, people who are not responding to their initial, to the initial thing they're assigned. It was, yeah, we could, so it was always, I think it was always clear to everybody that people who were randomized the active medication combination would not be eligible for re-randomization. But the, placebo non-responders would be eligible for re-randomization at some point in the study, was sort of the most specific we were with the sites. And I'm going to show you a couple of different graphics of what the study design looked like. And we did have 2 post-medication follow-ups at week 13 and at week 16. Talked about the okay. And there were, within this active medication phase, which includes both the stage 1 and the stage 2, patients had twice weekly clinic visits with urine drug screen collection for outcomes. Oral medication was dispensed weekly. And again, part of that was about blinding the time of re-randomization, so that if patients were getting medicine each week, right, they could have been re-randomized at any point within that. And the injections were given every 3 weeks. And this is and this study was actually given an IND waiver specifically around some of these questions. So the package insert for extended release naltrexone describes giving it every 4 weeks. But the blood levels probably start to drop off around the end of the 3rd week. And so we, to really maximize medication exposure, got permission to give it every 3 weeks. And then the treatment response The at least 3 of 4 urine drug screens negative, at least 3 urine drug screens negative for methamphetamine was measured in the last 2 weeks of each stage. And I'll show you some more of that as well. This is the concert diagram for the study. We had 403 randomized participants. In the first randomization, 109 were randomized to the active medication combination. So the other things I want to point out is patients received either naltrexone and bupropion together, or they received both placebos. This was explicitly a test of the combination. And so these folks who were randomized initially, the active medication combination, their outcomes are assessed at the end of stage 1. They whether or not they were responders, and they continued on the active medication throughout the study. 294 participants were initially randomized to placebo. There was a small number of placebo responders. They didn't change. They just stayed on placebo. All of the placebo non-responders who came to a study visit at the time of re-randomization were eligible to be re-randomized. There were a total of 225 who were re-randomized, and then they were equally divided among active medication combination or placebo. So if you're trying to figure out who gets analyzed when, this shows you the intent to treat combination. So I'm going to present data for stage 1 and stage 2. Stage 1 compares the people who were initially randomized to active medication combination to everyone who was randomized to placebo. Stage 2 looks at only the folks who are re-randomized and again compares the active medication combination to the placebo. Okay, so baseline characteristics of folks in the trial. We did have more men than women. This somewhat matches the demographics of methamphetamine use disorder, in which there is a male predominance, although this is a little bit more of a male predominance than we might have expected. The patients were mostly 40-ish, plus or minus 10 years. Half had never been married. A third were unemployed. Little more than a third were unemployed, but also a little more than a third were employed. I think that was sort of fascinating for us to think about using methamphetamine at least 18 out of the last 30 days and also being employed. And we had some folks who were essentially professionals who used methamphetamine as like a performance enhancing drug kind of throughout their workday. And 2/3 of the patients had a more than high school education. 85% of the participants were not Hispanic or Latino, and about 70% were white. Okay, I made reference to the fact earlier that in fact most of our participants used much more than 18 out of the 30 days prior to consent. So each of the columns is one of our study sites. So this is South Carolina. This is Washington State. This is New York City. Hennepin is in Minneapolis. Suru is San Francisco. This is UCLA. UT Health is Houston, and UT Southwestern is Dallas. So we had both coasts as well as the middle of the country, which felt really good to us. And again, matches had a decent match for where are the places that methamphetamine is a serious problem. The Southwestern site had fewer participants because our site, having a site here at Southwestern, was actually added midway through the trial. This mean is the mean number of days of methamphetamine use in the 30 days prior to consent. You can see it is well above 18 at an average of 26 to 27 days. And then this is the baseline use of intravenous methamphetamine. All of these data are self-reported. It ranges from between a quarter to almost half, and averages out at about a third of the participants had IV use at baseline. And then we think of IV use as being a marker of disease severity. So the most important thing to walk away with is that the primary efficacy outcome was significant. So we were able to demonstrate a significant difference in the number of medication in the number of people who achieved response between the active medication combination and placebo. So in stage 1, these are folks who this is that initial randomization to either placebo or active medication. And these folks were evaluated at weeks 5 to 6 of the study. The placebo responders, there were about 3% who met the response criteria compared to 16.5% in the active medication combination. When we look at stage 2, so this is everybody who's re-randomized, 2% in the placebo met the response criteria versus 11% in the active medication combination. That is a statistically significant difference with a number needed to treat of 9. This graph comes from the New England Journal publication. So you're looking at the left on the naltrexone bupropion group, patients randomized to active medication combination. On the right, you're looking at the placebo group. Blue bars is that stage 1, yellow is stage 2, and green is the weighted average. And so you can see there's a difference overall of about 11 percentage points in response rate between the medication combination group and the placebo group. There's lots of other ways of looking at these data. So this is methamphetamine negative urine samples. So higher numbers is better, is less methamphetamine use is higher. And this is going by study week. So you've got naltrexone bupropion in the pink line, placebo in the green line. This is for stage 1. Part of what you can see is how quickly, so at baseline about 5% of the urine drug screens are negative for methamphetamine. You can see how quickly the naltrexone bupropion group separates from the placebo group. And then again, when we look at the folks who are re-randomized, right, so their baseline is now week 7, right after re-randomization, they're overlapping. And then again, those who have been re-randomized to the medication combination separate quite quickly from those who are randomized to placebo. And the next, this is actually my favorite way of looking at the data. So each row is an individual participant. Red boxes are a urine drug screen that was positive for methamphetamine. Green is a urine drug screen negative for methamphetamine. So more green means that the patient is responding to the medication, and is having fewer urine drug screens that contain methamphetamine. This is and the blue line, above the blue line, these are the placebo responders. Below the blue line are the medication responders. So first, there's many more people below the blue line, so more people have showed a response to the active medication combination than to placebo. And also you can see sort of, again, how quickly we see this medication effect. By about week 3, you're really seeing the green boxes popping in. And weeks 5 to 6 are shaded because this is the stage 1 responders. So this is when they're evaluated. And then, and I mentioned, well, they were continued on active medication, but they're not part of the analysis. You can see that most of these people maintained that abstinence during the study, which would suggest that there's a benefit here for relapse prevention, although again, we didn't actually assess that. This is the stage 2 responders, so this is among the people who are re-randomized. Again, above the blue line are the placebo responders. There's only 2 of them in this one. Below the blue line are the active medication responders. And so these folks are re-randomized here around week 6, between week 6 and week 7. Week 7 is their first week on the active medication combination. And again, kind of a week later, you're starting to see much more green, which is really encouraging to think that patients can respond to a medication in a couple of weeks. So the medication combination overall was well tolerated. Overall in the study, there were 17 serious adverse events. Those were about equally split between active medication and placebo. Of all of the serious adverse events, only one was attributable to medication. About 95% of all adverse events were mild or moderate. There's a whole list of things that were more common in the active medication group. The only two that were statistically significant in both stages of the trial were nausea and vomiting. And that's almost certainly a naltrexone effect. Though keep in mind, we were doing 450 milligrams of bupropion, and the trial had a very fast titration. And so there could have been some jitteriness, discomfort associated with the rapid titration of bupropion. So if you read any of the commentaries about this study, the common knock on the study is, well, gosh, even with medication, you only got 13% of people to reach the responder status. Yes, that's compared to 2% of the placebo. So there's a lot of improvement there. And again, if you look at effect sizes and number needed to treat, that's a number needed to treat of 9. And that's very consistent with the number needed to treat across other pharmacotherapies for addictions, including naltrexone for heavy drinking, naltrexone for abstinence and opioid use disorder, and bupropion for smoking cessation. So these were the ADAPT-2 study sites, which I mentioned. The PI for the site in New York was Ned Nunez. For the site in Minneapolis was Gavin Bart. For the site in South Carolina was Susan Sunny. So site at UCLA was Steve Shoptaw. The site in Houston was Joy Schmitz. For the site at Southwestern was my colleague, Siddharth Wakalu. For the site in Washington State was Kat Wiest. And for the site in San Francisco was Philip Coffin. These NIDA clinical trial network studies have a huge team. We had a big team here at Southwestern with sort of mentoring and support from Walter Ling at UCLA, folks from the NIDA Center for Clinical Trials, and then the Data and Statistics Center and the Clinical Coordinating Center were run by the EMIS Corporation. And then Alkermes donated the naltrexone as well as just matched placebo, but had no role in data analysis or publication. So now we're going to switch gears and talk about the other recent evidence for a different medication to be effective for the treatment of methamphetamine use disorder. This is work that comes from Philip Coffin and the Department of Health in San Francisco. They specifically looked at the effects of mirtazapine for methamphetamine use disorder among cisgender men and transgender women who have sex with men. And this work was published in JAMA Psychiatry last year. Their study objectives were to assess the efficacy of treatment with mirtazapine at 30 milligrams daily to reduce methamphetamine use among men, where men is defined as both cisgender men and transgender women, men who have sex with men. This was assessed via urine drug screens, and their specific outpoint times were weeks 12, 24, and 36 of treatment. And then their secondary outcomes were to assess the efficacy of the treatment on decreasing risky sexual behaviors. And their key inclusion/exclusion criteria were DSM-4 TR, methamphetamine dependence. This is just a slightly older study, so they were still working under DSM-4. They had to study participants had to have a urine drug screen positive for methamphetamine during screening. They had to be interested in reducing or stopping methamphetamine use, had to be either assigned male at birth, or if they were assigned female at birth and identified as male. They had to self-report having sex with men while using methamphetamine in the past 6 months, and they had to be medically safe to participate. There are some ways in which the two trials have very similar participants in terms of actively using methamphetamine, meets criteria for a methamphetamine use disorder, and interested in reducing or stopping use, but how each trial operationalized that's a little bit different. And again, this is specifically looking at the question around men who have sex with men and use of methamphetamine in that context. So this was a double-blind, placebo-controlled, randomized clinical trial. They had 2 what they called run-in visits prior to randomization that assessed participant adherence to study procedures. Then participants were randomized to either mirtazapine at 30 milligrams daily or to placebo at a 1-to-1 ratio. They actually had they got 15 milligrams of mirtazapine in week 1 and then bumped up to 30 for the rest of the study. There were once weekly clinic visits, which included 30-minute counseling sessions. That's actually quite similar to ADAPT 2. I just didn't mention we had 20-minute, what we called medical management visits. And this was a 24-week study where outcomes were assessed at 12, 24, and 36 weeks. ADAPT 2 was shorter than that. Sorry, this is sort of a messy slide. So this is a much smaller trial. They had 120 overall participants, kind of similar age participants in their early 40s, majority white, again, and the majority of their trial participants were cisgender men. The breakdown between employed and unemployed was a little bit different. They had about 68% who are not employed, where that number was higher. The number of not employed was lower in ADAPT 2. And in terms of frequency of methamphetamine use, they ended up with a pretty heavy use population, where the most common frequency of use was 5 to 7 days per week. And they had about 40% at baseline who had injection drug use. Okay, so these are their primary outcomes. And this is looking at the percent of urine drug screens that were positive for methamphetamine. So here, lower number is better. The urine drug screens that were positive for methamphetamine were lower in the mirtazapine group in their intent to treat analysis. You can actually see at baseline, the mirtazapine urine drug screens were slightly, the urine drug screens positive for methamphetamine was slightly higher at baseline in the mirtazapine group, and then at each time point is lower than it is in the placebo group. It's easier to see here. So this is study week going across the x-axis. This is positive. This is results positive for methamphetamine along the y-axis. Higher number, more methamphetamine use. So we want to see the numbers getting lower. That shows a medication response. Placebo is in blue, mirtazapine is in yellow. And here you start to see the two groups separate out from each other about 9 weeks into the study. And then the mirtazapine line remains lower than the placebo line throughout the rest of the trial. These are their secondary outcomes, looking at a whole variety of risky sexual behaviors, number of partners with whom you use methamphetamine, anal sex with people who are serodiscordant. Many of these results have some statistical significance at week 24 that show benefit of mirtazapine, but these were not sustained at week 36, and you also don't see them at week 12. So there is some suggestion that mirtazapine at some time is decreasing risky sexual behavior, but it's hard to say how long-lasting of an effect it is. In terms of safety, mirtazapine was tolerated quite well. I think any psychiatrist would tell you that mirtazapine 30 milligrams is just fine. There were 9 serious adverse events, none of which were attributable to study medication. And as expected, drowsiness and weight gain were higher in the mirtazapine group than they were in the placebo group. So, take-home points, there remains no medication with an FDA approval. You've got 2 emerging pharmacotherapy options. One is the one that we tested in ADAPT 2, the combination of bupropion and naltrexone, and the intervention tested by Philip Coffin's group, mirtazapine at 30 milligrams. Specifically, the combination of bupropion and naltrexone increases the likelihood of a medication response, which is 75% of urine drug screens negative for methamphetamine, among patients with moderate or severe methamphetamine use disorder and heavy methamphetamine use at baseline. And mirtazapine decreases the likelihood of a urine drug screen positive for methamphetamine among men who have sex with men at 12, 24, and 36 weeks of treatment. Okay, so I threw in, these are my kiddos. I had one as a resident and one as a fellow. And when I was in training, I always liked to know that people did things outside of work. And then I mentioned that I have funding from the ABPN for an innovation award And that's to create this podcast known as the Yeah No Journal Club, in which I and some colleagues talk about the psychiatry literature and recent findings in the psychiatry literature. And so if you want to hear me talk about a variety of recent journal articles, you can take a listen to the Yeah No Journal Club.